To chair this session, I cordially invite the following revered individuals to the stage. Professor Ajit Mallasekara and Dr. Hilary Fernando. The topic for the next lecture will be minimally invasive surgical therapies in BPH is a worthy contenders for TURP. Over to you, sir, to introduce the revered speaker.
Good morning. So the first plenary now, this session will be by Ms. Danielle Whiting. She's a consultant urological surgeon from Firmly Park Hospital NHS Foundation Trust, United Kingdom. Over to you, Danielle.
Right, well, thank you very much for inviting me back to give another talk. Hopefully this one will be slightly less controversial than my first talk this morning. So, as we know it, the first TURP was described in 1926. It's then taken over 70 years before more endoscopic treatments were described. And TURP has therefore become something that we are very familiar with, that is efficacious, safe, and is a good option in the treatment of BPH. Naturally, it then becomes the comparator for all new treatments. But over the last couple of decades, we have seen an explosion of new treatments on the market and the rise of the so-called MISTs, minimally invasive surgical treatment options. So why has there been so much hype surrounding MISTs? Well, put very simply, the general appeal is that they offer minimal or no blood loss, that they have the potential to preserve both erectile and ejaculatory function. They can be delivered in an outpatient setting under local anaesthetic and often are associated with very quick recovery, which in an era where our waiting lists are forever growing has to be taken very seriously. So I'm going to start by reviewing some of the MISTs that we have available today and then go on to review some of the new contenders. So looking first of all at UroLift. UroLift involves the insertion of permanent implants which causes compression of the prostatic tissue. I'm sure most people will be familiar with the LIFT study and the 5-year outcomes comparing UroLift to sham, which showed that there were significant improvements in IPSS, quality of life and flow rate, which was durable. There was no effect on erectile or ejaculatory function, and the 5-year surgical retreatment rate was 13.6%. But how does UroLift compare to TURP? Well, we've got one RCT, which has compared the two, the BPH 6 study, and in both arms of this study, there were significant improvements in IPSS and quality of life scores, as well as Qmax. But as you can see, at the 2-year point, IPSS and Qmax improvements were superior with TURP, although there was no statistically significant difference in the quality of life scores. The quality of recovery, which they defined as a score of 70 or more, was statistically significantly better in the UroLift arm. When they looked at sexual function, erectile function was not affected in either arm, but ejaculatory function was superior for UroLift, although there was no difference in the bother scores. Looking then at incontinence, they measured incontinence by the Incontinence Severity Index, and that was unchanged with UroLift throughout the study. But with TURP, there was a significant deterioration at 2 weeks and then again at 3 months. And in these patients who experienced incontinence, it was also linked to a decrease in their quality of life scores. The retreatment rate at 2 years was higher with UroLift at 13.6% compared with 5.7% with TURP. In terms of adverse events, none of the UroLift patients required an early return to theatre, but 2 TURP patients required return to theatre for bleeding. There were no blood transfusions in either arm. The other differences in adverse events relating to incontinence and sexual function we've already discussed. This is a very small study, it's just 80 patients, and clearly that neither of the therapies come out on top for all of the parameters. So perhaps what we're saying here is that we need to be offering more individualized treatment to our patients. Next, moving on to Resume, which involves injecting water vapor into the prostate, resulting in necrosis. Similarly to the LIFT study for UroLift, the 5-year outcomes of Resume versus sham found that there were significant improvements in IPSS, quality of life and flow rates that were durable with preserved erectile function. The 5-year surgical retreatment rate was 4.4% for Resume. Comparing Resume to TURP, we do now have one randomized control trial that compared the two, and that was published earlier this year in 100 patients, looking specifically at prostate sizes between 50 and 120 grams. There were significantly higher improvements with bipolar TURP for IPSS, quality of life scores, and Qmax to the 2-year follow-up. In terms of sexual function, there was a statistically significantly worse IIEF scores at 2 years with TURP. They didn't look at validated scores for ejaculation, but reported on the rates of retrograde ejaculation, with one patient experiencing that in the Resume arm compared to 80% of the TURP patients. With adverse events, there were very little differences between the two arms, actually. The only significant difference was that of bleeding, 4% with Resume, 10% with TURP, but the authors didn't comment on whether or not any of these patients needed a return to theatre. And then finally, there was a significantly lower operative time and length of hospital stay for Resume, but notably a longer length of catheterization. So again, very similar to Urolift versus TURP, there are benefits to each of the procedures, which is going to be based on what the patient wants at the start of their journey. Moving on then to the third of our established MISTs, iTind, the temporarily implanted nitinol device. It remodels the prostatic urethra and bladder neck by applying continuous pressure, which results in ischemia. The device is then typically removed after 1 week. We have one RCT which compared iTind to sham, following the patients up for 12 months, and there were 175 men in the study. They measured their primary endpoint as being a 3+ improvement in the IPSS score. And at 3 months, there was a significantly better improvement with iTind compared to the sham, although there seemed to be a significant response with sham as well. By 12 months, that was durable, with very similar rates of improvement. But what we don't have is the longer-term follow-up data. And how does iTind compare to TURP? Well, to my knowledge, at the moment, there are no RCTs comparing the two technologies. There are several systematic reviews and meta-analyses that have tried to draw comparisons, but the problem is they're basing all of their comparisons on this one RCT, so it's very, very difficult for us to draw to any conclusions, and at the moment, we need to watch this space. And just when we thought the landscape of BPH treatment was complex enough, we do now have some new contenders for MISTs. Many of you will have heard of Optilume, first introduced in the treatment of urethral strictures, but we now also have the Optilume BPH catheter system. So this delivery system combines both mechanical dilatation with concurrent delivery of paclitaxel as an antiproliferative. It involves the insertion of a pre-dilatation balloon, which is inserted and inflated and held there for 1 minute. After the 1 minute, the balloon is deflated and removed. The paclitaxel-coated balloon is then inserted and inflated again in position and held there for 10 minutes. It certainly shows promise, combining the two mechanisms of action, that perhaps maybe this might have more durable results. The early studies demonstrated significant improvements in symptoms and flow, and this has led to the Pinnacle study, which compared the Optilume catheter system versus sham in prostates of 20 to 80 grams. The study randomized 148 patients and found significant improvements in both Qmax and IPSS, which was durable to 12 months, and they've recently published their 2-year outcomes showing that, again, it's durable to the 2-year point. Similarly to the other MISTs, there was no impact on erectile function. They had 4 patients that reported ejaculatory dysfunction, although that wasn't statistically significantly different to the sham arm. And when they published their 2-year results, their ejaculatory function scores are actually better than they were at baseline. In terms of serious adverse events, they had 4 patients that had significant hematuria that either required a cystoscopic management or a period of prolonged catheterization, and one patient who had a urethral false passage requiring prolonged catheterization. There are a number of mild to moderate adverse events, most commonly hematuria, but they report that all of these resolved quite early on in the patient's recovery, with a median resolution rate of hematuria at around 34 days. So Optilume has already been granted FDA approval last year. We're obviously still in need of some longer follow-up data to assess both the durability but also the safety of the delivery of the paclitaxel. And at the moment, there are no comparisons to TURP, so it's difficult to know whether this will contend. Moving on then to echo laser. The echo laser is an ultrasound-guided, micro-invasive laser ablation of the prostate, which can be delivered through a transperineal approach, similar to that of doing a transperineal biopsy. It's a solid-state diode laser with a 1064 nanometer wavelength, and it's also being marketed for laser ablation in other organs, including thyroid, breast, and liver. The way that it works, the procedure is marketed as being performed under local anaesthetic, so delivering perineal anaesthetic and then a periprostatic block. You then perform an ultrasound to undergo your treatment planning to identify the areas of the prostate that you want to ablate. 2 needles are inserted into the middle of each lobe, and then the optical fibres are inserted down the needle, and low power laser energy, typically 3 watts, is delivered for a few minutes. This produces an ellipsoidal shaped area of coagulative necrosis, which overall then reduces the size of the prostate. At the end of the procedure, the patient has a catheter in, and we do have a little bit of data to show how it compares to TURP. There's 1 RCT, but in a very small cohort of patients, just 51 patients. They were mostly looking at how it performed in terms of sexual function. They've only reported those outcomes to 1 month. And they demonstrated that there was better postoperative ejaculatory function with the echo laser compared to TURP, with no differences in erectile function. In terms of urinary outcomes, TURP offered significantly better improvements in Qmax, but there was no difference in IPSS or quality of life scores. Clearly, it's a very small sample size, just 51 patients, and with a very short duration of follow-up. So we still need to wait to see whether or not this is going to be a contender for TURP. So to go back to our original contenders, our original question, do we have some contenders for TURP? Well, I'm not sure that we should be thinking about it in that way. We have data that shows that MISTs are effective, durable, and safe. Are any of them better than TURP, or are they just complementing what we already have? We may get some answers from the upcoming PREMISE trial, which is a randomized trial comparing TURP, Rezum, Urolift, and ITIND. But what we should be thinking about is offering our patients individualized treatment, identifying the needs, what they want to achieve from their surgery. What one thing is for sure is that the future of MISTs is very exciting, and it's here to stay. Thank you very much.
Thank you very much, Daniela, for sticking to time and that very informative lecture on minimally invasive therapy on BPH.